This is FX Medicine. I'm Andrew Whitfield Cook. We're at the 2019 UIC Medical Cannabis Symposium, Tweed Heads, and we're talking with Professor Simon Eckermann. Simon, welcome.
Thank you.
Simon, tell us a little bit about your positions in not just the University of Wollongong, but what is it, the Australian Health
Services
Research Institute.
Yep.
Tell us a little bit about those and also where your history began with your interest in medical cannabis.
So I've been working at Wollongong for almost 10 years now, but before that I was at Flinders University as professor there, and prior to that the NHMRC Clinical Trials Centre. I'm known internationally for a lot of methods research and finding robust methods to inform joint decisions of research, reimbursement and regulation. And it's really from that background that I became interested in medicinal cannabis, because there's naturally joint questions around research, regulation, and also the reimbursement of medicinal cannabis products. So in reality, the methods I've shown how to ostensibly look at any given area and highlight what the joint optimal research, reimbursement, and regulatory methods are. And those are characterised in the book I've written, Health Economics from Theory to Practice, and the course I've taught for the last 15 years of that same name, which I developed with Andy Whelan from Canada at the University of Toronto, the sort of top biostatistician in the field, and have taught many times in many different settings, both in Australia and overseas. The methods we develop there naturally apply to medicinal cannabis in many settings. So I've done previously a lot of research in palliative care, been part of the National Palliative Care Collaborative, along with David Currow and Mira Agar, Janet Hardy and various other palliative care researchers. And a lot of the issues in medicinal cannabis, and particularly the work that United and Compassion do, is around those palliative populations. We have, certainly internationally as well as in Australia, about 90% of medicinal cannabis is for symptoms of pain, and particularly chronic neuropathic pain, and predominantly in those elderly populations. They're not to say there aren't younger populations, but those things interest me, as well as the palliative setting, where naturally we're not just interested in health-related quality of life and survival, as most clinical areas are. In a palliative setting, you're interested in finalising affairs, you're interested in people being in the community they want to be in and with the people they want to be with. And palliative patients from the Palliative Care Collaborative and many research pieces of excellent research done by researchers I've been involved with, like Dr. McCaffrey, have essentially shown that those three things, finalising affairs, being in their community of choice and being with the people they want to be with, they value before they start talking about their own health-related quality of life or survival. So they're very much first, second and third line. So it's that background really that I came to medicinal cannabis with. And when I got to medicinal cannabis, I was very interested because it's very different from a lot of the other work I've done, which has been in areas with individual-based therapies, where they use single-agent therapies.
Yeah.
So in many pharmaceutical settings, etc., and I sat on the Pharmaceutical Benefits Advisory Committee for 5 years, helping rewrite their guidelines in 2008. The nature of what you look at, you're looking at homogeneous, and you're trying to get homogeneous treatments and therapies, and you're looking at them applied in a population where the same homogeneous therapy is applied in those populations. In the cannabis setting, medicinal cannabis setting particularly, we're looking to take advantage of the entourage effect, and the entourage effect ostensibly means that you're not looking for single-agent therapies. You're looking for things which can take advantage of the synergistic effects you get between terpenes, CBDs, THC, and a lot of other minor cannabidiols, terpenes, etc., and flavonoids. And those things mean, compared to single-agent therapies, you get typically in pain populations that I've looked at, which constitute, as I've said, the vast majority of use internationally, you get a very distinct synergistic effect. So you get about twice the proportion of the population in a study done by Johnson et al. 2010, 43% got significant pain relief, significant being greater than 30% pain relief with terpene-rich THC to CBD 1-to-1, which means you have the full spectrum of the plant in that therapy, compared to THC alone with 23%, and opioids alone where you had 21% with a significant pain. So it's very clear you get therapeutic benefit. You also get much better dose response curves, which Galilee and Matulam, as well as particularly Ethan Russo, have shown in many publications now. And because of that, you're not really trying to get a homogeneous single-agent therapy. You're trying to do almost exactly the opposite, which is get these positive synergistic effects, which both reduce side effects, increase therapeutic benefit, and indeed, if they're optimised, if you get the best terpene expression, actually turn out to be the cheapest therapies as well to develop, if you can get develop them with a plant form versus a pharmacological form.
Right, so this is the big issue. I've said it before, the big elephant is basically, even if you can get access, the patient has to then buy it.
Yes.
And we have real issues. So we're going to be putting a graph up on the FX Medicine website that will detail the research and what you've teased out with regards to the different efficacies and costs. So let's go through that a little bit further. So when you're looking at single agents, actually no, you explain the graph. That's the best thing. I'll get lost.
Yep.
So if you think to me it's basically a triangle showing the differences between single agent pharmacological interventions, and then you've got what do you call it, patented medicines from a cannabis thing, and then, as you call it, agronomically grown products. Is that right?
Not strictly, but
no, keep going.
So in terms of what I've basically shown, if you synthesize all the evidence together, and that's what health economists do, we synthesize all the evidence, and the evidence around the relative treatment effect, the science, and particularly important in this case, we've got the entourage effect we want to account for, but then about the potential options that you have in terms of alternative therapies. And there's two very distinct pathways you can go down. You can go down a pharmacological pathway, and the first drugs which were developed in that setting, they tried to synthesize single-agent therapies where they'd have THC alone or CBD alone.
Right.
And those therapies are nowhere near as effective as keeping things in the whole plant form. So then developed something called Sativex, which does have whole plant extracts. In the process of extract, of course, though, you lose some of those synergies. So there's no perfect way of extracting things to get things to turn into a single pill, which is basically what pharmacological therapies do. And it did improve significantly, however, on the single-agent therapies. So that evidence I described, the Johnson et al. Trial, was of Sativex versus THC alone and versus opioids. Now, in reality, the Sativex, when it came out with value-based pricing, was incredibly expensive. And in Australia, that was initially about $28,000 per year to get the equivalent dose or equivalent dose amount to what you would have in a plant-based setting for pain management. That is a lot more expensive than the single-agent therapies, but as we saw, much more effective. In reality, if you can grow the varieties in the right environments and with the right seeds, and so it becomes getting the right genetic stock, and very much an agrarian issue, how you grow it, the seeds you're using to grow, and getting maximum terpene expression both in terms of the potential of the seeds and the way they're grown, then you can do a lot better than Sativex. And that's certainly been the experience of the Israeli use of medicinal cannabis, which since 1996 have ostensibly grown medicinal cannabis in greenhouses and outdoors. Outdoors you get much lower cost, but you also get better terpene expression. You don't get problems with mold. You're not using lights and fans and dehumidifiers and things which regulate soil, etc., as you are in indoor setting, and you're getting better terpene expression.
Yeah.
And that's really critical because that's the thing which is driving the entourage effect. So in terms of the pharmacological frontier, you can see that it's up on the right of that diagram. You have much higher costs, and you're getting much, in this particular case with the diagram, you're looking at the proportion of the population who don't get significant pain response. And so that 21% with opioids who do get significant pain is equivalently...
Which was stunning.
Yeah, is 79% who don't get pain response. 77% don't get pain response with THC alone, because the 23% do. Sativex, you get 43% who get pain response, so equivalently 57% don't. When we start the curve for the model based on what you might call an agrarian model as opposed to a pharmacological model, you can certainly get many different varieties grown. It's not one single agent therapy, and typically you would give those varieties as they do in Israel with precision medicine and customise the individual needs of the patient, where they would typically have CBD-rich and terpene-rich varieties during the day, and then THC-rich varieties at night.
And terpene?
And terpene, yep. So always terpene-rich. But you need to, as a physician, but also as in terms of the health system, to have the availability and the bioavailability of these different varieties. And that really is about getting the seeds and the growing conditions right. So terpene-rich varieties, you ideally get them grown in the right microclimates, outdoor conditions, and you ostensibly, in Australia, we have the ideal growing conditions. Terpenes are very much just their smell.
Yeah.
So in our wine industry, we know all about terpenes, and we have all the microclimates in Australia, everywhere from Tasmania to northern New South Wales, and even just into Queensland with the Granite Belt, where we get fantastic terpene expression, every type of microclimate you could imagine. Very much the same thing arises with medicinal cannabis varieties. You can get the right microclimates in Australia, from Tasmania up to northern New South Wales and even into the Granite Belt, that high country in Queensland, to grow the very best, highest quality terpene-rich varieties, and at minimal cost. So the cost of these varieties to grow, based on the RAND Corporation's evidence and indeed what's happened in Israel, we know that the cost of distributed cost of growing these with good agricultural practice and good manufacturing practice are more like $1 a day per patient, so $365 a year rather than $28,000 a year of Sativex. Yeah. And that difference, the difference between the $28,000 and the $365, really represents what I call the agronomy pharmacology gap, and makes it clear that we should be going for the agronomy frontier. You can improve on that with various approaches, particularly in Israel, with groups where they have been identifying what are the optimal varieties and different combinations of THC, CBD and terpenes for specific patient populations, and then even for specific individuals, to see their response, and then have second, third line, etc., with different terpene-rich cultivars.
And is that where you see the line rising towards the left-hand side of that graph, where you'll see an improvement in pain relief and a slight improvement in cost? I think you said it was something like $4.50.
Sorry, yeah. So you're going from up to about $4 a day. Yeah. So, but that, I mean, that's I'm saying that's part of that's hypothetical in terms of the cost.
Right.
In terms of the effects, they're definitively showing that the Sativex did have kind of suboptimal terpene profiles compared to what you could have, and naturally also the combination of therapies. So we're talking about in that region about using precision medicine, so where doctors can use not just one variety with a patient as you would with a single agent therapy. They can use typically two varieties of things, but maybe multiple varieties, and indeed also have the ability, if patients aren't responding, to switch over to other varieties which have different terpene expressions, different CBD to THC relationships along with terpenes, and have the potential to bring further effects, benefit at a population level. But in doing that, of course, the cost is going to rise somewhat.
Yeah, but it was not significant. It was nothing like...
No, so two very distinct frontiers.
Yeah.
The pharmacology frontier, you get a loss in terms both of the effect being less, and particularly on the right-hand side of that pharmacology frontier, you'll see the single-agent therapies, which are highly ineffective relative to the full spectrum-based pharmacological theories, but also relative to the full spectrum use of plant-based therapies. And in addition to that, with things like Sativex, where you actually do have the full spectrum, much higher cost, and the potential for significant benefits, even relative to Sativex, in terms of pain relief in those populations. So we both get a cost gap, but also a net benefit gap associated with the lower cost, but also higher effectiveness. Now, in that graph, it's still an underestimate. We're being highly conservative here, because this graph is just the direct cost of the therapy.
That's right.
If we allow for the downstream cost of the therapy as well, the more effective therapies, which you see to the left-hand side of that graph, will have lower costs associated with hospitalisations, in pain management, and particularly in palliative populations that we're talking about. And it's there that the research of Swissison and Duckett has shown that on average, if you can avoid a patient not having to go to hospital in a palliative setting, and palliative patients avoid them going to hospital, you save about $13,000 per patient. And if you had that in, for instance, just 22% of the population, you'd save on average about $3,500 per patient. And so that cost curve on the left would actually move even further down depending on how far you've moved in terms of a lower proportion of the population with significant pain problems and the system cost savings for the health system.
So we can not just have cost savings for the system, the direct cost to the patient, but also as a potential crop to save our farmers from economic destruction.
Well, certainly, I mean, one thing I should highlight in that same diagram is that to actually be internationally competitive and have the highest quality and the highest expected effects and have the availability of the toolkit for in any kind of physician, but particularly in palliative patient physicians to use, to have the variety of terpene-rich and THC and CBD-rich varieties that you need, and typically there's about 40 which Tickenolum have identified in a very nice table they have. But increasingly, the more sophisticated researchers now have about 700 varieties. They would typically use those main 40, but some of the new varieties coming along may well be even better. But I mean, beyond that diagram, there's also within this space the ability to improve the microclimates. So we have the ideal microclimates, and that's why we can move even potentially further. Now, if we do that, Australia has a natural comparative advantage if we go down that pathway. Currently, we're very much, in terms of our regulation, on the single agent focused pharmaceutical pathway, and that's very much what the TGA have focused on, and the Office of Drug Control. You really need to give the process of cannabis regulation, as they have done everywhere else in the world, in Canada and the Netherlands, in Israel, but indeed almost every other country in the world, to a body, independent body, with health objectives, with health department objectives, rather than prohibitionist objectives, which have been the case with the Office of Drug Control, and TGA objectives, which have looked at medicinal cannabis as though it is a single agent drug, as opposed to considering it as a plant and the potential you get for entourage effect and the potential you get for lower cost production, and then also the health cost savings to the entire health system from the resulting better therapeutic benefit and also lower side effect profile that you get from those plant-based therapies. In that respect, I should say that medicinal cannabis is very much like vitamins and vegetables. So if you take vitamins and you overdose on them, you end up becoming intolerant to them and needing massive doses to get the same, and eventually with all sorts of side effects, etc. Take the vegetables, you have exactly the sort of same thing. Natural plant form, your body has the ability to absorb it. It enables better dose response situation, and certainly over time is what I'm really saying. Over time, it's critical. So long term, and for chronic pain patients, that's what you need. So if we really want to overcome the problems we have with opioids, the answer is not to go to another drug, it's to go to the plant, medicinal cannabis, use it in a way which is precision medicine, customises the individual needs of the patient, and indeed the individual daily functioning needs of the patient. So CBD rich during the day and THC rich at night.
It's, I mean, there's so many facets of this, and obviously I would implore everybody to watch Simon's full lecture that he gave. But it really smacks that we can improve. I guess the thing is we should listen to the plant. I think that's the big lesson. Use it responsibly, but listen to the plant. I can't thank you enough for sharing these insights into that. That small graph has so much information. Yeah. And I've got to say thank you so much for sharing that.
There's one small thing I should add, and that is that in terms of really answering fully that question around the export potential of Australia and the potential of farmers, if we do go down that regulatory route where we are optimising, we do have a health system objective, we're getting for the individual patients in Australia what they need in terms of compassionate access, and particularly in palliative populations. At the same time, we'll be having the lowest cost, highest quality seed, growing techniques in terms of the microclimates, etc. And the end day, we get a product which has huge export potential. So if Australia does want to become a serious exporter, it needs to go down that route to actually be competitive, to have the highest quality at the lowest price, and make an international contribution and really exploit the comparative advantage of our microclimates. Now that market is currently worth, according to the latest estimates, about $14.5 billion, but by 2025 it's $55 billion. So there is incredible potential there if Australia does follow a route where it both helps the patients domestically get onto the appropriate therapies to maximise their net benefit and using precision medicine with plant-based therapies, but it also has enormous potential in terms of export once those things are set up to be done on scale and an export industry.
Wise words. I hope our legislators and governments are watching. Professor Simon Eckermann, thank you so much for joining us on FX Medicine today.
Thank you.
This is FX Medicine. I'm Andrew Whitfield Cook.